Now let's move on to cardiovascular pathology. This is a very high-yield topic on the exam. Let's start with common congenital heart diseases first. Now, before we begin, let's discuss cyanosis a little bit. Now, why does it occur? It occurs because you do not have enough oxygenated hemoglobin. Well, where do you see signs of low oxygenated hemoglobin on a physical exam? So you look at highly vascularized tissues, where the tissue that covers these vessels is very thin, such as the lips, the ears, the mucous membranes, the conjunctiva, and the nail beds. So cyanotic babies have blue lips, blue ears, blue mucous membranes, such as in the mouth. They have blue conjunctiva, and they have blue nail beds. Now, what is the difference between early and late cyanosis? Early cyanosis means that we have signs of poor oxygenation immediately after birth, and late cyanosis is something that takes more time to develop. The mnemonic for the 5 cyanotic lesions you need to know are the 5 T's. We have tetralogy of Fallot, transposition of the great vessels, truncus arteriosus, totally anomalous pulmonary venous return, and tricuspid atresia. So let's go through these 5 early cyanotic lesions, and then we can discuss the late ones. All right, let's get this thing started with a PTA, or persistent truncus arteriosus. The problem here is that the aorticopulmonary septum that is supposed to divide the truncus into the pulmonary and the aortic outflow tracts fails to form properly. Do you guys remember which types of cells are important in the migration and the twisting of this septum? That's right, neural crest cells. So here is our image representing the persistent truncus arteriosus. There's almost always an accompanying ventricular septal defect because the descending AP septum is supposed to fuse with the interventricular septum to complete the separation of the right and the left ventricles. So this image shows us what we are dealing with. There's one big vessel sitting over the unclosed interventricular foramen here. So what's going to happen? Well, we're going to have blood from the right and from the left mixing. They're both going to be dumping into this one huge vessel. So the blood from the right side and the left side are draining into this one truncus root. And then the pulmonary artery here and the aorta will then branch off later. So why does this make the baby cyanotic? The baby is cyanotic at birth because very low oxygen tension blood from the right side of the heart is mixing with the left side of the heart. Notice how they're both draining into this one common trunk due to the ventricular septal defect. Okay, great. Now let's go ahead and move on to the next one. This is detransposition of the great vessels. D meaning dextro, which is right. Transposition literally means flipped to the opposite side. So in dextro transposition of the great vessels, the origin of the aorta is on the anterior side and displaced to the right. We can see that here in this image. So the right ventricle is now going to be pumping directly into the aorta, while the left ventricle is going to be pumping into the pulmonary artery. Is that normal? Absolutely not. Why? Because we have 2 completely different circuits. On one side, we have the superior vena cava dumping into the right atrium, dumping into the right ventricle, and then into the aorta. On the other side, we have the left ventricle pumping directly into the lungs, then into the left atrium, then back into the left ventricle. At what point are these 2 going to mix? That's the problem. We need another defect, such as a VSD here or an ASD here, to mix the 2 bloods, because currently they're 2 different circuits. We have to have another defect to allow the mixing of oxygenated blood with deoxygenated blood. Obviously, these kids need surgery to reposition these vessels. Now, what about tricuspid atresia? This one's really quick. So tresis is Greek for perforation. Whenever we slap on an A in front of a word, it means without, right? So tricuspid atresia is without perforation due to some abnormality of the tricuspid valve developing. So tricuspid atresia literally means there is little or no communication between the right atrium and the right ventricle. This means that the valve is not going to develop correctly. So if we do not have a functional right ventricle, then how are we going to get blood into the lungs? We need an ASD and a VSD to be able to appropriately get blood into the pulmonary circulation and mix it with oxygenated blood. Okay, excellent guys. Let's keep rolling here with a really high yield one, Pathology of flow. This is an important slide. We're going to start with the pathophysiology and tie in all of the bullet points in your first aid book as we go. So the basic problem in this disease is that the infundibular septum here is way too anterior and superior. The septum never descended in the correct way, so we never closed off this interventricular foramen, and now we have a VSD. Now, what else does the shift of this infundibular septum do? As you can see here, it creates a very stenotic opening for the right ventricular outflow tract. So this malpositioned septum did several things. It also left the aortic root sitting directly above this VSD. This is called an overriding aorta because it overrides the normal flow of blood from the right ventricle into the pulmonary artery, because the stenosis here to the opening of the right ventricular outflow tract, aka the pulmonary artery, is impeding this normal circulation of flow into the pulmonary vasculature. This right outflow tract obstruction causes the right ventricle to hypertrophy and increase the wall thickness. This gives the heart a classic boot shape, which you can see here. The hypertrophy from pumping against the stenotic opening and also shunting across the VSD into the overriding aorta creates significant hypertrophy that adds mass to the right ventricle, and on X-ray you can see this. It is literally a boot-shaped heart. Now it says in your book that the pulmonary stenosis forces flow from right to left. But how does it do this? There is such high resistance by trying to pump into this tiny diameter of the opening of the pulmonary artery that it just makes more sense to go through the VSD into the left ventricle and then into the systemic circulation. It doesn't matter that the pulmonary vasculature has very low resistance if we can't get past this impedance here at the very beginning. So this is important in understanding the physiology of an early cyanotic TET spell. A TET spell is when decreased oxygen levels being delivered to the brain makes these kids get grumpy and cranky. So how do they fix this? So these kids will do something like a squat. And by squatting, they increase the afterload or total peripheral resistance because they compress the arteries in their legs. This results in decreased flow into the aorta and more flow across the stenotic opening. Because we've increased the pressure here, now there will be a little bit more of a gradient for blood to stay on the right side and not shunt from right to left. When you get more blood to the right side, you get more blood in the lungs, and you get increased oxygenation of blood. The brain likes that, and the kid starts to be less cranky because his TET spell is now over. You have to surgically reposition and connect this infundibular septum to where it normally is supposed to go, because this is the main problem in the entire disease. So now let's move on to the last of the cyanotic heart defects. Okay, so total anomalous pulmonary venous return. Let's orient ourselves to this image. This image is showing the right and the left pulmonary veins dumping back into the heart. Here's the right atrium. Do you see how the right and left pulmonary veins are draining into the right atrium? Is this bad? Yes. Oxygenated blood returning in the pulmonary veins should not be going to the right side of the heart. We'd ideally like for that to say left atrium, but guess what? It's not. It says right atrium. Pulmonary veins are supposed to deliver oxygenated blood to the left atrium, but as you can see in this image, the right and left pulmonary veins are dumping blood directly into the right, not left atrium. What is the consequence? We get no oxygenated blood delivered to the left side of the heart. So what do we need in this situation for this kid to survive? We need another defect, so we can mix deoxygenated and oxygenated blood together. We need an ASD, a PDA, a VSD. We need something for these kids to be able to survive. Now, what about left to right shunts? Left to right shunts result in late cyanosis because it is the chronic overflow from the left side to the right side and into the lungs that will eventually overwhelm the right side of the heart and the pulmonary circulation. So in order of decreasing frequency, number one is VSD. What's next? Followed by an ASD, and then a persistent ductus arteriosus is the least common of these left to right shunts. Something that is particularly high yield to know is that the VSDs usually close on their own. All right, now let's talk a little bit more about those. Ventricular septal defect. Remember, there is an interventricular muscular and an interventricular membranous septum. The muscular septum develops from the growth of the myocardium, and the membranous septum grows down from the endocardial cushion. Most of the VSDs are associated with failure of the membranous septum to develop. Most of these are asymptomatic at birth, but they can become a problem later on if they do not close on their own, or if the lesion is particularly large due to right heart volume overload. Several quick things. VSDs, number one most common, usually a defect in the membranous septum associated with endocardial cushion defects, and these usually close spontaneously. Now let's move on to another type of septal defect, atrial septal defects. This image will help remind us that there are different types, right? It's not just one. Now the most common is an ostium secundum defect. Remember, the ostium secundum was originally a perforation in the septum primum. Secundum ASDs are usually caused by insufficient growth of the septum secundum to cover the opening. Now in your book it says that the septum primum defects usually occur with other cardiac abnormalities. Why is this? It is because the septum primum has a very close association with the endocardial cushions. Now endocardial cushions are very involved in heart embryology. An abnormality with an endocardial cushion usually leads to more than one defect. Excellent guys, let's keep pushing to a patent ductus arteriosus. This is a very important fact. It really tests your understanding of cardiac physiology before and after birth. It is important to know that the ductus arteriosus usually connects the aortic arch distal to the left subclavian artery. Sometimes you can have a slight overlap with the ductus connecting a little bit proximal to the left subclavian artery, but most of the time this is not the case. So the flow arrows here are after birth. But while the baby's in the uterus, the flow from the right ventricle is going to enter the pulmonary artery and then bypass the lungs by going directly into the systemic circulation. So again, from the right ventricle into the pulmonary artery, we bypass the lungs completely and we dump straight into the distal aortic arch. Blood that crosses from the right atrium into the left atrium via the foramen ovale will then enter the left ventricle and take care of the upper extremities and head by these branches. There's no need to send a lot of blood to the lungs because they do not participate in oxygen exchange. They're full of fluid. So what happens after birth when the pulmonary vascular resistance drops and the foramen ovale closes? Now blood that is traveling in the ascending aorta will preferentially shunt back across the ductus into the pulmonary circulation. Remember, this is after birth, and this happens because the pulmonary vascular resistance is so low when that baby takes the first breath and all of the pulmonary vessels open up. So this oxygenated blood that should be traveling in the aorta to the rest of the body is going to now be shunted back into the lungs. And how will this present clinically? Well, first of all, there is a continuous machine-like murmur because the pressure gradient for this flow from the aorta back into the pulmonary circulation is there in systole and it's also there in diastole. So there is constant flow across the shunt. Now what can we do for these kids? We can help close the ductus by administering an NSAID, indomethacin. Indomethacin is useful because it inhibits cyclooxygenase and prevents the production of any prostaglandin E2 or I2. Now what would happen if the ductus remained open? We get something called differential cyanosis. Why? The head and the upper extremity are going to be well perfused because blood from the left ventricle will go into the aorta and then go into the great vessels branching off the aortic arch. This is occurring before the shunt. Everything proximal to the patent ductus will be well perfused. So the upper extremity, such as the head and arms, will be fine. Now what about after the shunt? Distal to the shunt, there will be cyanosis. So it is not okay. This difference between the upper and lower extremity is called differential cyanosis. The head and arms are going to be pink, well perfused. The lower extremity will be cyanotic, will be blue. This is a big difference between the upper and lower part of the body, hence they named it differential cyanosis. Now we move on to the big bad dog. This is Eisenmenger syndrome. So the reversal of an uncorrected left to right shunt to a right to left shunt is called Eisenmenger syndrome. Let's incorporate some physiology here because that is how your test question writers are going to test you. So what do we know? We know that a change in pressure with a delta sign next to it equals flow times resistance. We know this equation well from the physiology section, but let's rearrange some stuff to help us understand the pathophysiology of Eisenmenger syndrome. So since pressure is a change in pressure, let's actually include what we're talking about. We're talking about pulmonary artery pressure minus the pulmonary venous pressure. Now, what is the equivalent of pulmonary venous pressure? The pulmonary capillary wedge pressure, right? So we can replace this with pulmonary capillary wedge pressure. And remember, we get this using our Swan-Ganz catheter. So now we can say the pulmonary artery pressure equals the flow, which is Q, times the pulmonary vascular resistance, which is R. And we switched this pulmonary capillary wedge pressure, we added it to the other side so that we can calculate for the pulmonary artery pressure, because that is the problem in Eisenmenger syndrome, is the development of pulmonary artery hypertension from a reversal of this shunt. So we have now this equation here. So the way this equation looks now makes a lot of sense. An increase in flow leads to vascular remodeling. This is how it happens in a left to right shunt. The increase in flow can lead to vascular remodeling. The vascular remodeling will then lead to a decrease in the lumen of the vessels. This decrease in the lumen of the vessels will increase the pulmonary vascular resistance. So now we've increased flow, we've also increased resistance. What is this going to do to our calculation of pulmonary artery pressure? This will increase the pulmonary artery pressure. The remodeling that occurs due to this increase in flow is due to continual shear stress on the right side of the heart. Remember, it's not used to this kind of overflow, but the shunt is giving the pulmonary artery as much blood as it can handle all the time. The shear force leads to damage of endothelial cells. When endothelial cells are damaged, they get angry and they release stuff like endothelin-1. Endothelin-1 is a very vasoconstrictive agent. It also tells vascular smooth muscle cells to join the party, and they come into the intima. So it says, vascular smooth muscle cells, come join us in the intima where you're not supposed to be, and it also tells them to vasoconstrict. In addition to that, these vascular smooth muscle cells start growing out of proportion. Here's an image of what's happening. Look at the lumen. It is absolutely tiny. The proliferation of vascular smooth muscle cells within the tunica media pushes and constricts the lumen to the point we are going to greatly increase the resistance. How does this affect the right ventricle? It's going to now have to work very hard to contract against these elevated pressures and increase resistance. How is it going to do that? Well, it's going to compensate by increasing the wall thickness. So we're going to have right ventricular hypertrophy. So why does this shunt reverse? Well, remember we said the pulmonary artery pressure is increasing due to an increase in flow and an increase in resistance. Do you think the right ventricle is going to want to pump this way into this very narrow lumen? Or is it going to take this route and start now reversing the shunt and going from right to left? It's going to take this route, right? So much easier. This process takes time. This is why Eisenmenger syndrome is late cyanosis. You see symptoms such as clubbing. Now, what is clubbing and how does the low oxygen tension in the blood lead to this? So this hypoxemia activates the transcription of hypoxia-inducible factor, and this occurs in the kidney. Hypoxia-inducible factor is a transcription factor that leads to the production of platelet-derived growth factor, vascular endothelial growth factor, and erythropoietin. Now, what do all these things do? Well, EPO increases the production of red blood cells, leading to polycythemia. Platelet-derived growth factor tells fibroblasts to start depositing tons of collagen. And when you do this in the nail bed, you increase the diameter of the nail bed and these fingers look like little clubs instead of normal digits. This accumulation of tissue gives us the increased fingertip mass and the increase in the nail plate curvature. This was called clubbing by someone, and that's what now we look for when you're worried about cyanosis producing other signs. Alright, now let's resume with some other anomalies. This one is coarctation of the aorta. So coarctation means congenital narrowing of the aorta. So this is close to where the ductus arteriosus was. Now we have a remnant, ligamentum arteriosum. Two big associations that we need to be aware of here are that a coarctation can usually occur with a bicuspid aortic valve or in conjunction with Turner syndrome. So expect a vignette describing a girl with Turner syndrome in addition to physical exam findings of higher pressures in the upper extremities compared to the blood pressure recordings in the legs. So the upper extremity will have much higher blood pressures. Now you might also be asked about the collateral circulation used to get around this coarctation or congenital narrowing of the aorta. This image is going to be key in helping us understand what we're talking about. So again, here's this narrowing of the aorta very close to the location that the ductus arteriosus was previously located. Here we can see the remnant, the ligamentum arteriosum. So blood cannot go down the aortic arch because of this narrowing. Where is it going to go? It's going to go into the internal thoracic, so you can see it's flowing here. Then it's going to go into the anterior intercostals. So the anterior intercostal arteries connect with what? They connect with the posterior intercostals. The posterior intercostals then connect directly to the aorta, and we can resume the normal circuit of flow. This is how we bypass this coarctation. Now, they're not going to ask you this directly. Rather, they're going to show you an image like this. Now, where do these anterior and posterior intercostal arteries run? They run on the inferior aspect of all of the ribs. So this means that on X-ray, you will see little notches. Here, 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 here. They're everywhere. Why are these notches being created and why are we able to see them on X-ray? Because the dilated intercostal arteries that are having to handle much more blood than normal are pushing up against the rib from the underside and eroding the periosteum. So this is the classic rib notch finding that we see in patients that have coarctation. The collateral circulation leads to this physical exam finding. Now, another potential question you could be asked is to identify the chromosomal anomaly associated with Turner syndrome if this were to be a Turner patient. We know that Turner syndrome patients are XO. They're missing that second X chromosome. All right, let's keep moving on. I think a flash quiz is going to sneak up on us. Tetralogy of Fallot is caused by the displacement of what structure during embryogenesis? The infundibular septum. Remember, the infundibular septum is displaced anteriorly and superiorly, causing the very stenotic opening to the right ventricular outflow tract. That stenotic opening, in conjunction with the VSD, leads to the other physical exam findings of cyanosis, right ventricular hypertrophy, and the boot-shaped heart that's classically seen on X-ray. Now let's keep on pushing.